Next, we'll move on to the clinical features and the diagnosis of heart failure in a patient. So the clinical manifestations of heart failure may include symptoms and also clear physical exam findings that we can detect when examining a patient. So on the symptoms category, left-sided heart failure symptoms are often because of increased pressure in the lungs or edema in the lungs. And as a result, patients may tell us that they're feeling short of breath, either at rest or with exertion or both. They may tell us that they feel short of breath when lying flat, because as the patient reclines, the pressure increases, the preload is going to increase, and as a result, if we're not able to adequately get blood out, pressure will build up in the lungs and cause patients to feel short of breath. So they'll often say, you know, I'm sleeping sitting up, or I have to sleep with 5 or 4 pillows under my head in order to feel comfortable, and that's what's known as orthopnea. Some patients will wake up in the middle of the night, have to sit on the edge of the bed and gasp for air and not feel better until they're sitting up for a few moments, and this is known as paroxysmal nocturnal dyspnea. So I often will ask patients, do you wake up in the middle of the night? And if so, what wakes you up? And if they say something like, I felt anxious, or I felt like I couldn't breathe and I had to sit up, that's likely paroxysmal nocturnal dyspnea, or PND. Some patients will cough. Many patients will feel fatigue. And interestingly, a recently recognized sign or symptom that many patients endorse and is associated with very elevated filling pressures in the heart is a symptom called bendopnea, which is basically where patients will feel very short of breath when they bend over to pick something off the floor or to tie their shoe. And that's because of dramatically increased preload when the patient is bending over. So this is bendopnea, and it's a fairly sensitive physical exam finding. Patients who are manifesting right-sided heart failure symptoms, which ultimately may be because of left-sided dysfunction, but you know, they're manifestations of right-sided heart failure as well, would be peripheral edema, so lower extremity edema, or right upper quadrant discomfort. Patients may also have bloating, poor appetite, early satiety, anything that is going to affect the motility of the intestines may be a manifestation of right-sided heart failure. As far as physical exam findings, the patients may be diaphoretic, they may be tachycardic, they may have a high respiratory rate, they may have pulmonary rales or crackles, they may have a loud P2, and they may or may not have an S3 gallop, which would be indicative of the big dilated baggy heart, or they may have an S4 gallop, which is generally associated with a stiffer, high pressure heart. Probably the most sensitive physical exam finding for volume overload in patients is the presence of jugular venous distension, which we'll talk about in a minute, peripheral edema, or hepatomegaly. So all of these things may be present. So in my opinion, the most important physical exam finding that we should be assessing in everyone in whom we're looking at a heart failure diagnosis is the jugular venous pulsation. And this actually can be very difficult to see in patients who have very thick necks or have limited neck mobility. And even in patients who don't have those things, sometimes this is a very subtle physical exam finding. But in numerous studies, this has been found to be one of the most sensitive physical exam findings for the presence of increased filling pressures in the heart. And so this is just 2 pictures of where we're looking here. So generally, we want to have our patients at about a 45-degree angle laying down with adequate lighting, and then have their head basically turned a little bit to the left so that we have a view much like the view here. And where we're looking is to see where the internal jugular pulsation is present on the neck. So we're not necessarily looking for EJ or external jugular distension. We're really looking for the internal jugular pulsation underneath. In some patients, it's very difficult to discern this from the carotid pulsation, which is generally going to be the more profound pulsation that you see in the neck. But some tricks to try to discern this would be to provide some pressure on the right upper quadrant and see which one of the pulsations increases with that pressure. That's the venous pulsation. And then also the carotid pulsation is generally sort of a single waveform. As you can imagine, it's an arterial waveform, where the venous pulsation has kind of a double wave, as we see that C wave, the A and B waves in patients. So this is a skill that I think requires looking at many jugular venous pulses before feeling good about assessing this. And even for those of us who spend day in and day out looking at jugular venous pulsation, sometimes there's some clinical kind of not being sure what it is. But it is probably one of the best physical exam findings to tell us what the volume status in our patient may be. Hepatojugular reflux is using, again, the patient is in that 45-degree angle, and we're applying pressure for a full 30 to 60 seconds at the right upper quadrant. And what we're doing here is displacing blood flow into the venous system. And in a patient who has volume overload, when we let go of that pressure, what we see is in everyone, the jugular venous pulse will go up when we apply pressure to the liver. In somebody with normal filling pressures, the jugular venous pressure will come right down once we remove the pressure of our hand on the right upper quadrant. In the patient with volume overload or heart failure, that jugular venous pulsation will stay elevated for a few seconds longer. So this is a very difficult exam finding, and generally it requires excellence at detecting where the jugular venous pulse is, but this can be a helpful adjunct to the jugular venous pulse. And all of this would correspond to if you had access to an echocardiogram and you could look at the inferior vena cava, we would see that the inferior vena cava is dilated, as in this patient, and would show evidence of reduced variability with the respiratory rate. So normally the IVC should decrease by about 50% with respiration. You should see a variation of about 50%. And in a patient with volume overload, the IVC will be dilated and will have blunted respirophasic variation. The other findings on a physical exam may be an S3 gallop, which is going to occur during diastole, and it may represent an above average volume of blood entering the ventricle. And the patient should be in the left lateral decubitus position, and if you have a stethoscope with a bell, it's often best heard with the bell. Lower extremity edema is the classical physical exam finding associated with heart failure, as can be seen here. And it gives us a sense of how much volume the patient may have. And so this is sort of my own kind of guesstimation when I'm trying to determine how much extra volume a patient may have on board, to say if the patient has bilateral edema to the knees, it's probably about 10 pounds of fluid. To the thighs, probably 20. And if they have edema all the way up to the sacrum, they probably have in excess of 30 pounds of additional fluid requiring diuresis. Not every patient with heart failure will have lower extremity edema, but certainly it is a helpful measure of where a patient's volume status is. And if you have access to a chest X-ray, we may see evidence of effusions, of pleural effusions, or of increased interstitial markings or pulmonary edema, curly B lines with fluid between the fissures, an enlarged heart, as in the case of this patient, and we may see mediastinal fullness or hilar fullness due to dilatation of the pulmonary vasculature. Other imaging that's important, if you have access to it, would be to get an echocardiogram to assess for the left ventricular ejection fraction, valvular function, and wall thickness. And laboratory testing is also a helpful adjunct to assessing the patient, particularly looking at their renal function, liver function, thyroid function, and if you have access to it, natriuretic peptides, which are biomarkers of stretch that increase in states where the myocardium is stretched due to volume overload. And in particular, the Breathing Not Properly study, which was published in 2002, showed that BNP, or B natriuretic peptides, were helpful at distinguishing between shortness of breath due to heart failure versus shortness of breath due to something other than heart failure. As you can see here, the base level of BNP in a heart failure patient was on average around 600 or more, whereas for a non-heart failure patient, it was about 200. And then for somebody not having any dyspnea at all, the level was closer to 50. So when a patient comes into the hospital and they're manifesting some of the signs and symptoms that we've just talked about of heart failure, what may be the cause if they have a known diagnosis of heart failure? And the first thing we're going to do if they've never had these symptoms before is think about those differentials, that differential diagnosis list of whether this is an ischemic cardiomyopathy or a non-ischemic dilated cardiomyopathy, and make that diagnosis first. Once we've established why they have heart failure, we want to think about what the things that may be occurring that have led them to become volume overloaded may be. And in this study from 2001 in the United States, the reasons for why patients develop decompensated heart failure after being compensated for a while were several. Some were due to increased salt in the patient's diet. Sometimes it was because physicians inappropriately reduced patients' heart failure therapy. Less frequently was that patients weren't taking their medicine, but that is something that may cause patients to develop some of these signs and symptoms. Sometimes it was something non-cardiac, like a pneumonia or renal failure, and then sometimes it was due to arrhythmias, ischemia, and in a very large proportion of patients, it really wasn't clear why people had a decompensation. So that covers our diagnosis of heart failure and our physical exam findings.